Good afternoon, everybody. Thank you so much for joining us today. I'm so happy and thankful to Professor Andy Bush for talking today on Preschool Wheeze. Professor Andy Bush, he's a Professor of Paediatric Respiratory Medicine at Imperial College London. He is a Paediatric Respiratory Consultant at the Royal Brompton. He's got many other titles, including Chief Investigator of Breathing Together, which is a Wellcome-funded study investigating factors determining the development of childhood asthma. So thank you so much again for teaching us today, and we will really appreciate it. If there are any questions during the talk, please enter your questions using the chat function, and I will either interrupt Andy or save it towards the end, depending on what your question is. Okay, thank you so much.
Well, thank you very much indeed. Thanks for asking me. I've got a pretty tough topic to talk about, preschool wheeze, who gets what treatment. I hope this is going to be very informal. Do please interrupt with questions. Email me afterwards if there's anything that's not clear or anything you disagree with. So, quick as a flash, my slides don't seem to want to work. Sorry, Liz, they were working beforehand. What's gone wrong? Ah, here we go, better. Okay, so I've got no conflicts of interest. So the aims of my presentation, I'm going to discuss the clinical approach to a child who's for a child referred with preschool wheeze that is refractory to treatment. Now, I'm not quite sure what's good. I'm just going to describe the possible treatment options and how, for the first time, we're beginning to be able to personalize therapy in a practical way. I'd like to show you the potential of novel approaches to prevention, some of the successes and failures. And also, our job as pediatricians is to educate our adult colleagues. COPD is not an adult disease, it's a pediatric disease. And preschool wheeze is actually not something that's here today and gone tomorrow, but it signals a lifetime risk of COPD and all-cause death. So it goes a little bit beyond just who gets what treatment, but I hope that you'll find it educational and enjoyable. So first things first, the clinical approach. So most importantly, children with preschool wheeze fall into one of 5 groups and 5 groups only. And you need to use your clinical skills, history and examination to separate them into groups. The first and the hardest diagnosis of all is normal child. And we spend the whole of our lives learning what is normal and what is not normal. People laugh when I say I work at the Brompton because it's so easy, but it's easy because everybody who comes to see me is ill. It's much harder when you're out in the community working out which coughing child, which wheezing child needs referral. It'll be very few, will have a serious illness. This is rare, but it's important to get it right or you'll be on the front page of the newspapers. This is a child, I hope you can see my pointer. This is a CT angiogram. There's the right ventricle, main pulmonary trunk, right pulmonary artery. There's the left pulmonary artery coming off the right pulmonary artery and compressing the airways. This is a pulmonary artery sling. One of the asthma syndromes, which I'll talk about, minor problems which may mimic or exacerbate wheezing symptoms, such as rhinitis or reflux, and often the over-anxious, often first-time parents. As all of us know, some of us from first-hand experience, kids don't come with an instruction manual. So all that wheezes is not asthma, and the first thing is to take a good history and carry out a detailed physical examination with focus on both. And one very important teaching point, isolated chronic dry cough with no wheeze and no breathlessness is rarely, if ever, due to asthma. Yes, cough variant asthma does exist, but in the UK, we have overtreated it and overdiagnosed it. If they're not breathless, they don't have asthma. A few children whom you see in primary and secondary care will require investigations. Many need none. And rather than a scattergun approach, you need to target your investigations specifically. So what about normal? Important, but until you know about normal, you can't diagnose abnormal. So the post-viral, post-bronchiolitic cough, which may go on a long time. Importantly, about 10% of children have more than 10 colds a year and may have symptoms for 2 or 3 weeks with each cold. Many children have at least 3 episodes of otitis media in the preschool years. Pertussis and its relatives has made a comeback, particularly with fear of immunization. What I call nursery school syndrome. It's usually a first child. They go early into a childcare facility, a creche, because both parents are working. They get repeated viral infections, one viral cold merging into another with no time for pausing. And of course, because these are normal viral colds, they don't respond to any medication. So it's relatively easy by the time they come to me. They've run the gamut of antibiotics, bronchodilators, etc., etc. The prescription is a hot lemon and honey drink for the child and a large glass of wine for the mother, both to be repeated as often as possible. And I would very strongly commend to you this meta-analysis from the BMJ about the spectrum of normal childhood respiratory symptoms. And incidentally, I don't know if this, I think this is being uploaded. If anybody wants these slides, just ping me an email and I'm very happy to send them. But do read that meta-analysis. So specific points in the history. Is it really wheeze? People use the term wheeze in a very imprecise manner to describe all sorts of noises, true wheeze, crackly noises, snottering upper airway noises. We're increasingly using a video questionnaire to try to determine what parents are talking about when they say their child wheezes. Are there prominent upper airway symptoms? Are there symptoms from the very first day of life? And if there are, that child needs investigating. This is different from the baby who comes home and gets their first cold at 2 weeks of age because the older sibling has snotted all over them. If an experienced mother tells you this child had symptoms in hospital from the day of birth, that child needs investigating. The child with sudden onset of symptoms suggestive of a foreign body. The mother who says, my child was fine until Tuesday a week ago and has coughed ever since. This may be a young baby who can't bring their hands to their mouth, but they may well have a sibling who can give them a teddy bear with a loose nose, the nose finishing up in the airway. If they have a chronic moist cough, really important, if they've got the daily moist cough for 6 to 8 weeks, that child needs investigating. That is not asthma. That child needs investigating. The child who's worse after meals, irritable feeder, arching back or vomiting, think about reflux. Obviously look for systemic illness or immunodeficiency and continuous unremitting symptoms. So this is a very nice graph I pinched from a paper on tuberculosis. This child with recurrent symptoms, but well in between times, those are usually viral colds, that's normal. The child with the post-bronchiolitic cough, gradually improving, taking time, not much to worry about, but this one getting relentlessly worse and worse. Think about that. That's the one you need to be investigating. What about the physical exam? We'll look for clubbing, weight loss and failure to thrive. Every so often we see somebody on the ward with clubbing like that, which clearly did not develop overnight. Pediatricians are not good at looking for clubbing. We need to do that. Look for upper airway disease, tonsils, rhinitis. Look for nasal polyps. You can see one there. That's an obvious polyp. And if you see nasal polyps, the first, second, and third diagnosis is cystic fibrosis. It is said you can differentiate a polyp from an inflamed turbinate because the polyp doesn't hurt if you jab it with an orange stick. But no child that I've ever seen has let me go anywhere near their nose with an orange stick. Think if they've got an unusually severe chest deformity, could this be something more than just asthma? If they've got abnormal auscultatory signs. or signs of cardiac and systemic disease. All of these things you should focus on when you're taking your history and doing a physical examination to make sure you don't miss the child who has more than just idiopathic preschool wheeze. So can we diagnose asthma, and what does it mean for treatment? And the sterile question, which is a non-question, gets asked: at what age can you diagnose asthma? So what is this thing called asthma? Is it airway inflammation? Is it variable airflow obstruction? Is it bronchial hyperresponsiveness? A doctor said so. Somebody once gave me an inhaler. Or what? Now, I could take a vote on this, but like all the best children's games, everybody gets a prize because whatever you vote for is right. All these things have been used to define asthma in the literature. But asthma, to me, is an umbrella term, and it means wheeze, dyspnea, chest tightness, plus or minus cough. And the next question, if I say to you, your child has asthma, is to shoot back, what sort of asthma does my child have? That's at any age. And it's a bit like anemia. Anemia means a low hemoglobin. If you went to a hematologist who said, you've got anemia and go away, or just take some iron, you'd be horrified. You'd want to know, what is the precise cause of my anemia and what is the treatment? Same for arthritis, hot, red, painful joints. An umbrella term, and the rheumatologist you consulted would want to unpick which arthritis you had so you got the right treatment. So how does this work for asthma? Well, the answer is we need to deconstruct the airway. The airway is very stereotypic. A bit like a baby who can only show its displeasure by screaming, the airway has a very limited number of ways of showing that something is wrong. It can develop fixed and variable airflow obstruction. And you can see, although it may be bronchoconstriction due to smooth muscle constriction, you can see that these alveolar guy ropes around the airway holding it open, that if some of them have gone, that may cause instability. But the treatable tray that we should focus on, rather than sterile questions about, is it asthma? Does this child have bronchodilator responsiveness? If so, give bronchodilators. What about airway inflammation? Is there any? Is it beneficial? What are the pathways? But does the child have a treatable tray of airway eosinophilia? If it does, he or she does, then prescribe inhaled steroids. But just as you wouldn't dream of treating somebody with normal blood pressure with antihypertensives, why would you want to treat somebody whose airway is not inflamed with eosinophils with an anti-eosinophil strategy? Is there airway infection and impaired host defenses? If so, prescribe antibiotics. This is not original. This is the late, very great Freddie Hargreave, who was doing this 20 or 30 years ago. But the question, the way I would challenge you to think about airway disease is not, is it asthma, doctor? But what is the component? What components of this airway disease, particularly what are treatable components that this child has? So previously, we looked at symptom patterns in preschool wheeze. Did they have episodic viral wheeze, wheeze in association with usually a clinically diagnosed viral urti? It may not be transient. They probably don't have eosinophilic inflammation, therefore no inhaled steroids. Whereas the multiple trigger wheezer, wheezing both with viral colds and with triggers between colds, may well be eosinophilic. But this is pretty crude. It relies on the parental symptom reporting. And looking here, this is Professor Saglani's work. If you look at the clinical phenotype, viral wheeze, multiple trigger wheeze, you can see that some in both groups have airway eosinophilia, whereas there are some in both groups that are normal. What about atopy? Well, again, some atopic wheezers do not have airway eosinophilia. It is just simply not reliable. So let's think about treatment, bearing in mind we want to know what we're treating. What are the indications for treatment? Well, it might be prevention of disease progression from preschool wheeze to established atopic asthma. And people have looked at antihistamines and they failed. And people have looked at steroids and said, okay, if steroids are great treatment for established asthma, why don't we start them early and prevent the child getting asthma? Sounds great. I'll show you why it doesn't work in a minute. And the other is treatment of symptoms. And we'll go through some of these in a moment. So what about giving inhaled steroids very early? Well, the two studies, the IFWIN Manchester study and the PEAK study, both tried the effects of giving inhaled steroids to preschool wheezers early on before they really needed them, and it made no difference. The prevalence of later school-age asthma was the same. And this is the COPSAC study from Denmark, where they used intermittent inhaled steroids as opposed to continuous inhaled steroids, again, not disease modifying. And this is rather worrying. These are rather worrying data from the IFWIN study. On the vertical axis is airway resistance. The higher up you are, the more obstructed your airway. On the horizontal axis, placebo or fluticasone. And even those children who had one course of inhaled fluticasone in a randomized double-blind placebo-controlled trial subsequently had worse airway obstruction. Now, this is not to deter you from using inhaled steroids if they're going to work, but please do not use them just as a sort of non-specific airway tonic because you think it might be a good idea. So what about inhaled steroids? Well, this was a study by Nicola Wilson and Mike Silverman, characteristic a quarter of a century ahead of their time. They used inhaled budesonide in preschool children, and this failed to prevent episodes of wheeze. In this American study, they compared intermittent montelukast, intermittent nebulized budesonide, and standard salbutamol with preschool wheeze. They used nebulized budesonide because that is the only inhaled steroid that they are allowed to use in the preschoolers. I have not prescribed it for preschool wheeze for years and years and years. For this Canadian study from Francine Ducharme, they used this enormous dose of fluticasone, 1.5 milligrams a day, and this reduced prednisolone requirement, but it also switched off growth. And in this USA study, they compared nebulized budesonide continuously and intermittently, and they had the same effect on wheeze. Unfortunately, there was no placebo group, so we don't know if they were both equally effective or equally ineffective. Now, this is the first study, I wish I'd done it, the infant study, the first attempt to do realistic personalized medicine in preschool wheeze in a practical way outside an ivory tower. So they took 300 children aged 1 to 5 years. They were at step 2 in 18 North American sites, and they did a 3-way crossover study, blinded, and they compared daily inhaled steroids with daily leukotriene receptor antagonist with as needed inhaled steroids and salbutamol. They use a composite endpoint of asthma control days and time to an attack requiring oral corticosteroids. And they pre-specified aeroallergen sensitization, gender, and wheeze, key attacks of wheeze as pre-specified predictors of response. Importantly, they did not pre-specify blood eosinophil count. So this is what they showed. On the left-hand panel, 60 out of the 300, despite them having to be quite ill before they were recruited, got better over the next year, didn't have any exacerbations, and it didn't matter what you gave them. In the right-hand panel, you can see that those in the inhaled steroid continuous, the red arm, they were most likely to avoid an attack. Intermittent steroids, next best. Leukotriene receptor antagonists, worse. And they then, in their pre-specified analysis, looked at aeroallergen sensitization. And they showed that it was in the group with aeroallergen sensitization that inhaled steroids showed a differential response. They then did a post hoc blood eosinophil analysis, so this has to be hypothesis generating. And if you see if the blood eosinophil count was 300 or above, inhaled steroids worked well. Then the others less well. If the eosinophil count was less than 300, it didn't matter what you did. And if you combined post hoc eosinophil and aeroallergen count, those who were aeroallergen sensitized and had a blood eosinophil count of 300 or more were the group that responded to inhaled steroids. So here, for the first time, we have a treatment driven by in a personalized way in preschool children. We can all find out if they're aeroallergen sensitized. We can all find out if they've got a raised peripheral blood eosinophil count. Now, this needs to be confirmed because the eosinophils were post hoc. But to me, this is a really exciting study that we're making progress. And this is our work. We looked at induced sputum to see if that was a good marker of airway eosinophilia in preschool children, and it was not. That's different from school age asthma. If you had no blood eosinophils, it was likely there was none in the BAL. Of course, a blood eosinophilia may be driven by other atopic diseases like eczema. And of course, think carefully before you apply this in a low and middle income setting where there's a heavy parasite burden. A friend of mine told me in Costa Rica that everybody had a blood eosinophil count of greater than 5% because of parasites. Now, what about leukotriene receptor antagonists? So the hypothesis is cystinyl leukotrienes are raised in the acute episodes. Parents probably aren't going to medicate a well child. And the PREEMPT study from Australia showed that if you gave montelukast intermittently with viral colds, this was superior to placebo. And you've seen these data already. Intermittent montelukast was better than standard treatment. But in this huge study, over 500 patients in each limb, there was no difference in the primary endpoint between placebo, intermittent montelukast, and daily montelukast. There was some difference in secondary endpoints and a bit of fudging, but the primary endpoint was a failure. And this is Jonathan Griggs' weight study. Again, nearly 1,500 patients with a 1-year follow-up. Montelukast did not work. So, although there may be a few individuals who benefit, it is not generally a good medication, and it is at best a minority medication. And if you find that 50% of your preschool wheezers are on montelukast, you can be pretty certain you're over-treating them. And this is the scream, and it reminds me to tell you about the psychiatric side effects of montelukast, which may be as high as 20%, according to Francine Duchamp's work. Behavioral difficulties, night terrors, sleep disorders, usually gets better as soon as montelukast is stopped, but occasionally does not. You need to warn your parents about this side effect if you're going to use montelukast. So what's my hypothesized treatment? Episodic treatment for episodic problems. First choice is nothing more than bronchodilators. And but ask yourself, does the child need treatment at all? Anybody who's tried to give a spacer and mask and a medication to a screaming toddler will know that it is not a trivial issue. The next thing I do would be to trial leukotriene receptor antagonists with appropriate warnings, but they probably don't work. Next, I would try high-dose inhaled corticosteroids, but no higher than 400 micrograms of beclomethasone equivalent a day. And a counsel of despair is to combine the above. What about multiple trigger wheeze when they've got symptoms most days? I would commence treatment usually with 200 micrograms twice daily of beclomethasone equivalent via an appropriate spacer. I would see them in 6 weeks' time and ask the question, has the child symptomatically improved? If the answer is no, then they're not steroid responsive. Consider alternative diagnoses, consider alternative therapies. If they appear to be if they are symptom-free, stop the treatment and reassess the child regularly. And the next question, do the symptoms recur on stopping treatment? If no, then no action is needed. If yes, then you restart beclomethasone, titrate to the lowest dose needed to control symptoms. If you do this 3-stage protocol, on, off, on, then you will not overdiagnose steroid-responsive airway disease and muddle that with somebody with a prolonged post-viral symptom. What about macrolide antibiotics, which, as you know, are the cure for all known pediatric respiratory diseases? They have multiple anti-inflammatory and antiviral and other effects. And in this study, 158 asthma-like symptoms, whatever that means, in 72 children in the COPSAC study, symptoms were shortened by azithromycin. This was a more rigorous study. You had to enter it, you had to have had at least one course of prednisolone. 607 children, the azithromycin group got less prednisolone. However, in this study, in an emergency department in +1, absolutely no effect of azithromycin. So I would put to you that azithromycin may be a justifiable treatment in those with acute, really severe wheeze who've got a track record of HDU or PICU admissions. But if you give it out willy-nilly to every child with a cold who wheezes, antibiotic resistance will be rife within the community. What about prednisolone? Should we be using prednisolone in acute preschool wheeze? And this is a field where I confess that I have overused it. This is a meta-analysis. It's out of date, but I'll show you why it's out of date. 1,700 children in 11 studies in varying different concepts. I'll show you the data in a moment, but prednisolone had no effect on whether you were admitted to hospital or not. If you gave prednisolone as an outpatient, actually the placebo group did better. Emergency department studies, perhaps a small benefit of oral steroids. So panel A, hospital admissions, you've seen these plots before many times. The black diamond essentially straddles the central line, no effect on hospital admissions. Perhaps placebo better for outpatient studies, perhaps steroids better for the emergency department. Further results of the meta-analysis, again for all comers, did not reduce the need for extra steroids, but if you're an inpatient, perhaps there is a benefit. So here you can see that in panel D, no effect on whether you got more steroids, but panel E, yes, there does appear to be a benefit in outpatients. But overall, most children show no benefit. If they're well enough to stay at home, they don't need steroids. There's a hint that there may be some benefit in sicker patients, possibly a non-genomic effect reducing airway edema. But so 2 studies, this was in the Lancet Respiratory Medicine, 624 children, and this was actually not a good study. They changed the primary endpoint halfway through, and they showed that prednisolone was beneficial in their changed endpoint and saved 170 minutes in hospital. This is the Jonathan Griggs study, 687 patients, coincidentally saving exactly the same time period, 170 minutes, but this was not significant. So what do parents think? Parents in the audience, 170 minutes more in hospital or a course of steroids for your child? So I think prednisolone still has a role, but not in primary care and not even for every wheezer in secondary care. Possibly for a multi-trigger wheezer with a severe attack, and possibly any severe episodic viral wheeze heading for PICU. But we have overused them. I stick my hand up, me included, we've overused them. So how do we define future risk? Will this baby, this infant, go on to asthma? So these are probably the best data, an ROC curve, and it looks very impressive. The area under the curve is more than 90%, and the 3 things are acute attacks of wheeze, aeroallergen sensitization, and exposure to tobacco. This is a marker of a high-risk group for for infants who are going to go on to develop school-age asthma. And let's just think also about the developmental course, how lung function, how the development role plays out in these children. This is Global Lung Initiative data, nearly 100,000 records from 72 centres in 33 countries. They constructed predictive equations for spirometry, and you can see here the predicted FEV1 on the vertical axis, age in years on the horizontal axis. You can see they've done ethnic appropriate normal ranges, which to me is actually a nonsense. We can have that debate another time. But you can see that you increase your FEV1 up to about 2022 and then gradually decline. And your long-term outcomes are determined by three things: what your lung function is when you're first born, how your lung function evolves in the first 2 decades of life, and genes, infection, asthma, pollution, all important, and also how rapidly your lung function declines. And why lung function declines rapidly is not nearly as clear as once we thought. So I've said to you provocatively that COPD is a childhood illness. And this is the ECFS study, 13,000 plus young adults. And they looked at 5 risk factors of childhood deprivation: maternal and paternal asthma, which is not amenable to manipulation, childhood asthma, maternal smoking, and childhood respiratory infections. And you can see here on the horizontal axis age in years, on the vertical axis FEV1, and each line represents the number of risk factors you have. And you can see that if you have at least 3 risk factors, your lung function is worse across the spectrum. And whether or not you smoked, early childhood deprivation is associated with low lung function, no catch-up, a faster rate of decline, and more COPD. And FEV1, a low FEV1 in childhood, signals more than just a risk of COPD later on. And these are very challenging and very important. So this is from the Tucson study. 1,400 participants, mean age 26 years. This is perhaps the doyen of all pediatric studies in Tucson, Arizona. And they looked at terciles of FEV1 and mortality. And 122 of these children were dead at a young age. And if you look here, by the time the lowest tercile of lung function, the solid line, is associated with significant increase in all-cause mortality, even as early as the 3rd decade of life. Every 10% decrease in baseline FEV1 is predicted as associated with increase in risk of all-cause mortality. And you cannot think of any biological plausible way where losing a little bit of lung function is associated with heart disease, unless it is the fact is that this is a marker for other morbidity. And I don't have time to show you the data, but this is from other studies that confirm this. This is a miner, and he's got a canary in his cage. And the miner took the canary down the mines, not because he likes bird song, but because if the canary stopped singing, that meant it was dead. And it was dead of carbon monoxide poisoning, and the miner had better leg it up to the surface before he died too. And is FEV1, a canary in the mine, a sign of all-cause trouble ahead? Why is clinically trivial lung function loss associated with greater adult mortality? And interestingly, birth weight, which is a strong determinant of lung function, birth weight variability is driven by fetal genotype, 15% of it. And these genes are also the links with type 2 diabetes, fasting glucose, triglycerides, all sorts of cardiovascular abnormalities. So this is a plausible genetic mechanism whereby lung function and outcomes from non-lung function diseases, non-pulmonary diseases, could be linked. And this is maternal smoking. This is a meta-analysis of 18,000 children from 22 cohorts. They looked at DNA methylation. It was peripheral blood, not the airway, which is a weakness and inevitable. And in 3 loci, methylation, DNA methylation, epigenetic factors were significantly related to parental and adult lung function, whether you added in whether or not you added in adult smoking. You can see those 3 loci significantly affected, and all of these loci, methylation was significantly related to adult smoking, with a robust link to cardiometabolic risk factors. So there's more to the damage that you're getting than just COPD. So we've got a model of cigarette smoking crossing the placenta, the effects in pregnancy, causing low birth weight and affecting lungs that way, causing epigenetic modifications directly, and crossing the placenta to have systemic effects, not just on the lungs, but on the other developing organs. So the preschool wheezer he or she is not just got a transient childhood problem. This is a sign of trouble ahead. And this is a group we've got to find ways of doing better with. So finally, can we prevent asthma yet? Wouldn't it be nice? And the first thing is that something can be done. This is the Amish Hutterite study. The Amish and Hutterites fled Europe to North America because of religious persecution. The Amish continued to use very traditional farming methods. The Hutterites, the most modern agricultural methods there were. And you can see in this plot, they are almost identical populations genetically. So they've got the same genes, but a big environmental difference. And the Amish had a much lower prevalence of asthma and atopy, and a much higher environmental lipopolysaccharide, much different microbiological exposures in dust, and you can see the endotoxin levels much greater there. And very interesting, in human studies, the Hutterites had more bloody eosinophilia, the Amish were more neutrophilic. Amish monocytes had a suppressive phenotype, and innate but not adaptive cytokines were higher in the Amish children. And in a mouse study, if you took Hutterite dust and treated the mice, they got more airway eosinophilia, whereas Amish dust inhalation was suppressive of allergic airways disease in these mice. And Amish dust suppressed BAL cytokines and operated through the innate immune system. And this volcano plot shows the multiple genes that were up and down regulated in the 2 populations. And the important thing about this is that it gives proof of concept that if we were clever enough, we could do something after birth to modulate atopic airways disease. And in this study by Professor Saglani, again, using a mouse model, using Acinetobacter iwafii, it protects the mouse from house dust mite induced airway hyperresponsiveness. So you can see here that those mice treated with did not get airway responsiveness. There was some increase in IL-13's positive innate lymphocyte cells. House dust mite increased T cell positives, but this was abrogated by Acinetobacter, and same for protein. So, but the important thing is this dust, there's an endotype, there's a pathway in vivo in the mouse where it appears protective. But there are others, so we've got to focus, can we help our children? And smoke-free legislation, we've simply got to focus on that. This is a Flanders study. They sequentially tightened the noose on smokers, banned from workplaces, banned from restaurants, banned from bars for serving food. And they looked at the effect on this on preterm birth. And you can see from this very nice panel from Ben Nemri's study, every time we got more stringent tobacco-free legislation, preterm birth fell. We've got to advocate for our children for this. Banning smoking in public places. Does it benefit people? Well, this is the asthma admissions study from Scotland. Pre the ban, it was rising. In Scotland, you can see that the admissions are going up for asthma, and post the ban, it fell dramatically. And you can see here this dramatic fall in bans in asthma admissions in Scotland with a smoking ban. All ages, all socioeconomic status. What about tobacco in cars? Smoking in front of children banned in England in 2015, Scotland in 2016. Self-reported exposure in this study, again, an reduction in exposure. Legislation works, and you can see with the introduction of the ban, the solid line in England, the exposure drops. What about passive vaping? Public Health England says vaping is so safe. Well, in this study, volunteers vaping nicotine-containing and nicotine-free vapes, or occasional tobacco smokers. There was a lot of nicotine in the e-cigarettes, and they found substantial gas phase increase in toxins, increased urine cotinine nicotine metabolites. We do not want children passively inhaling this stuff. We've got to advocate against it. Pollution, is that important? Yes. 600 children who did spirometry at age 4 looked at residential exposure in pregnancy to benzene and nitrogen dioxide, and you can see the higher the exposure in pregnancy, the worse their lung function was at school age. It's worse if you were allergic, worse if you had a low socioeconomic status. And this is the Children's Health Study in South California, 3 successive time-dependent cohorts of 5 years each, during which time smoking pollution legislation was tightened. They looked at annual spirometry. This is a rather confusing graph because the x-axis goes in the opposite direction. So to the right of the x-axis, pollution is low, to the left it's high. And you can see in all these 6 cities, there was a beneficial effect as pollution levels dropped in terms of childhood lung development. Something else, this is another study. This is looking at fish oil in pregnancy compared with olive oil. 736 pregnant women randomized, nearly 700 completed. Persistent wheeze or asthma was the endpoint, and the risk of persistent wheeze was less with fish oil, especially if the mothers who had low levels of metabolites in the blood and had a low intake. What about vitamin D in pregnancy? Cures everything. So this was the 6-year follow-up of the VDART study, pregnancy multivitamins with extra vitamin D or a supplement, a small beneficial effect at age 3, which became significant when it was combined with another non-significant study from Denmark. Was this through antiviral immunity? But age 6, unfortunately, no difference either in VDART or in the Copenhagen study, no long-term beneficial effect of vitamin D. Interestingly, again, Professor Saglani's data, there were positive bacterial cultures in 50% of severe wheezers, irrespective of phenotype, whether they were persistent or transient. And you can see that those that were culture positive had more neutrophils, and Sagel defined 2 cultures, a Moraxella predominant culture and a mixed culture, looking at the microbiome. The Moraxella are associated with neutrophilia in the BAL. And interestingly, all wheezers in the Moraxella microbiome culture, but none of them were associated with rural living. The mixed profile was associated with rural living. And interestingly, again, bacteria, are bacteria the link? Bacterial infection in this study, Staph aureus applied to nasal polyps. upregulated the alarmins TSLP and IL-33 and type 2 cytokines. And you can see on the extreme right, the staph with Staph aureus increased type 2 inflammation, and this was also converted in a cellular study, and it was reduced by a specific TLR2 inhibitor. So what are my take-home messages? First up, preschool wheeze fits into 5 groups. History and physical examination is initially used for that categorization, and that is usually all you need. We are beginning to be on the verge of personalized medicine for preschool wheeze, rather than just putting steroids in the tap water. Acute attacks, atopic sensitization, and tobacco exposure predicts a high-risk group, not just for COPD, but for cardiometabolic mortality. And we are getting closer to strategies to move beyond palliative care with steroids for asthma and actually preventing the disease. Could asthma be caused by bacteria? Well, I'm old enough to remember a half-wit who thought the duodenal ulcer was caused by spirochetes, and everybody laughed their heads off until he infected himself with the spirochetes and got an ulcer, and now we treat duodenal ulcer with antibiotics because it's caused by Helicobacter. Maybe the same will happen with asthma, who knows? But don't say that in your MRC PCH exam. So thank you very much indeed for listening. Those are my grandkids, the traditional end to a study. 2 twins on the right. The third in the same outfit is much younger and belongs to another family. Thanks for your attention. I am told if you're not like me and clever, you can scan this and give feedback. I'm very happy indeed to take questions. Thank you.
Okay. Thank you so much for that, Andy. We have a couple of questions which came through to the chat group. One question is how to manage post-viral cough disturbing toddlers' sleep?
And that is an extremely good question to which I do not know the answer. Tony Milner did a study years ago to looking at post-RSV bronchiolitis symptoms, and he did randomized double-blind placebo-controlled trial with inhaled steroids versus placebo, and one group did much better than the other, and he thought, fine, I've cracked it, broke the code, and the placebo group did better. And he was furious. He tells this story very entertaining against himself. He was furious, sent off the inhalers because obviously the stupid drug company had mislabeled them, got them reanalyzed, and it was still the placebo group. The answer is nothing much works. And all I can offer is intelligent sympathy and say, look, I'm sorry. If I had the choice between being a junior doctor in the old days of doing a 1 in 2 or having a sleepless child, I'd take the 1 in 2 every time, because you get 1 night off every other night. So it's intelligent sympathy. I've not found, if anybody on the call has found anything that works, please let me know. I'd be very glad to hear of it.
Another question from Andre. The use of prednisolone for acute wheeze due to rhinovirus.
Yes, indeed, and that's a very good question, which I didn't touch on. There has been a study, I think, from Finland, which suggests that if you treat rhinovirus, acute rhinovirus wheeze with prednisolone, you then reduce the risk of subsequent asthma. Now, to my knowledge, the 2 problems with this study, to my knowledge, as far as I know, it has never been replicated. The second thing to say is that very few hospitals are routinely doing viral studies in children with preschool wheeze. And the thing that I also find difficult when you think of Jonathan Griggs' study of over 700 patients, unfortunately for funding reasons he couldn't do viral PCR studies, but a whole shed load of them must have been due to rhinovirus, and he didn't see any beneficial signal. So while I wouldn't discount totally the possibility that the rhinovirus finding is real, I don't think there's enough evidence to say that this is what should be done.
Okay, thank you. I've got another question. Shall we need to treat viral induced wheeze? I'm not quite sure what that means. I'll follow on to another question. What is better for infants, wheeze, budesonide, or flixotide?
So as far as I know, there has been no comparative study in infants, but either in terms of efficacy or side effects. So the short answer is use the cheapest. There is one other thing I didn't talk about steroid side effects. That there's a slight caution against using the most potent steroid you can get your hands on. And that is, we all know that if you give oral or intravenous steroids, we all know that that is immunosuppressive. We know that the airway contains a sophisticated network of immune defenses to stop us dying of pneumonia every time we inhale a bacterium. So why wouldn't inhaled steroids be topically immunosuppressive? And the answer is they are. There are adult studies where they've done that show that inhaled steroids treatment of COPD increases the risk of pneumonia. That inhaled steroids increase the risk of TB and atypical mycobacterial infection. So just be a little bit wary, and be a little bit wary of the very potent ones that may be topically immunosuppressive.
Okay, lots of questions for you, Andy.
Great.
So Heba's just come back. She means what regarding her question, shall we need to treat viral induced wheeze? She means, I mean, post-viral wheeze.
Yeah, the difficulty, post-viral wheeze is largely, at least in my hands, untreatable. I'd love to have a treatment for it. It can go on for 2 or 3 weeks or more. The family, the people talk about a happy wheezer. That's all very well, but the family may be rather less than happy if they've been kept up night after night by the child. The family may well know that, you know, this child's not acutely ill and doesn't need hospital, but it's a thorough nuisance for everybody. Unfortunately, I don't know of any treatment. Just simply say, look, it will get better. I'm really sorry. Try my hot lemon and honey drink red wine combination. But I wish there was something we could do that was useful.
Yeah. Another good question is, what is your opinion on the use of bronchodilators in under ones?
And a very good question indeed. Much less is known about wheeze under the age of 1 compared to wheeze 2 to 5. We don't know much about that. Very little is known about the under ones. I think it is perfectly reasonable to give a trial of either ipratropium or salbutamol or both via a mask and spacer, see if it works, and if it does work, continue with it. In terms of inhaled steroids, again, Professor Saglani's work when she was a research fellow, she studied preschool wheezers at the age of 1 year, first year of life wheezers, who were sent to Helsinki Children's Hospital. They were sick enough to go to Helsinki Children's to have a bronchoscopy, to have detailed investigations, and not one of them had eosinophilic inflammation. So I'm very, very, very anti the use of inhaled steroids in 1 and under. And even those who are atopic, who have bronchodilator reversibility, did not have eosinophilic inflammation.
More questions. So some advise to use Montelukast when one has viral wheeze, and others advise Montelukast usage throughout winter period. Which is better?
Being cheeky, I'd say both. I would say I wouldn't recommend either. Joking apart, though, of course, as the questioner implies, there are some children, very few, who do appear to benefit from Montelukast. I tend to give it as required at first. If they've got very rapid onset of symptoms, and then giving it regularly may be a strategy. But do remember the big studies, the weight study, the international study. You know, we've got something like that, more than 3,000 children showing no benefit. The evidence supporting the use of Montelukast is very, very poor indeed.
We've got, can we diagnose an infant with asthma early in life?
So yes, so this comes back to what do you mean by asthma? If you mean, does it have a clinical, the clinical syndrome of wheeze, breathlessness, and chest tightness? Yes, you can diagnose that. But what you can't do is say, like a penny in the slot machine, got asthma, give inhaled steroids. So I would say, first of all, 1 year and under, it is highly unlikely that this infant has got eosinophilic airway disease, and highly unlikely they need inhaled steroids. If they're 1 and over, if they've got a raised peripheral blood eosinophil count and are aeroallergen sensitized, they are likely to have the treatable trait of eosinophilic airway inflammation. So what I would rephrase the question is, can we diagnose an infant with the treatable trait of eosinophilic airway inflammation needing inhaled steroids early in life? And the answer is you can, with those 2 tests. And I think we should be increasingly trying to use those tests. You can actually now get a peripheral blood eosinophil count as a point of care test on a drop of blood. And I think we should be moving as far as we can to biomarker-driven treatment.
And I suppose I had a question for everyone in the DGH. At what point, Andy, would you like people to be referring to the tertiary centre? Obviously, if they had something like clubbing or very atypical features from, from birth, these are sort of red flags which should prompt immediate referral to a tertiary respiratory centre. But I'm remembering my sort of DGH days, we will see wheezers who come to A&E every single month. It will be the same thing. They're not admitted necessarily to the ward. Sometimes they might get admitted, sometimes they don't. What would you say? I suppose with asthma, there are sort of guidelines where we know if they have an HDU admission, if they have more than 2 courses of oral steroids, we know what the thresholds are that we should be referring to a respiratory specialist. What would you say that people should keep in their mind?
So the rough rule of thumb is, in any context, refer if the diagnosis isn't working, if the diagnosis is unknown, is unclear, if the treatment isn't working as anticipated, or if any party is unhappy. If the family are unhappy, get a second opinion. It's always the safest thing to do. I think if somebody has had an HG or a PICU admission, they should certainly be referred. Somebody who comes up to casualty on multiple occasions but is not admitted, I think I would, there were no red flags. I think the first thing I would be asking myself is, is there some strategy we can put in place to try to help and support the parents that they don't access casualty when they don't actually need them? And that, as Winnie the Pooh would say, is another story. But initiatives like Connecting Care for Children, delivering care and support in the community, may well be the thing they need to stop them coming to casualty, rather than getting a bronchoscopy done by me.
Yeah, fantastic. Thank you. Oh gosh, lots of questions. I think we'll have to say maybe 2 more. What is the second test for eosinophilic airway inflammation apart from eosinophil count?
So in older children and adults, induced sputum is very accurate. In preschoolers, maybe, but you can get induced sputum with hypertonic saline and a vigorous physiotherapist, but it doesn't correlate with BAL. So if in doubt, then I'm afraid it's an invasive test with a bronchoscopy and a bronchoalveolar lavage. And indeed, if we're thinking of a child of 6 and over, if we're thinking of using we're thinking of using a biological mepolizumab or omalizumab, we would certainly do that test.
Great, thank you so much, Andy, and thank you everyone for your questions, and really appreciate it. It was a fantastic talk, a lot to think about for everyone. Fantastic, thank you so much. Please give feedback.
Yes, thank you. Thanks all. Liz, thanks for organising it. I hope it's been valuable. Do please email me and do please give feedback, because also, if I've just allowed 1 minute of naughtiness, we're at the moment running in the sector lectures on Thursday morning, 8:30. on Zoom. If you've got requests for that, please let me know. Please let me know. Or training requirements. We won't know what you need for training unless you tell us. Somebody who's 100 years, it's 100 years since I trained, so unless you tell us, we won't know. So please do.
Thank you, Andy. All right. Bye, everyone. Have a good day.
Cheers. You too, Liz. Thanks all. Bye for now.